Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Tel Luca.
Welcome to the Thinking Practitioner.
Books of Discovery has been a part of massage therapy education for over 20 years. Thousands of schools around the world teach with their textbooks, their e-textbooks, and digital resources. In these trying times, this beloved partner is dedicated to helping educators with online-friendly digital resources that make instruction easier and more effective in the classroom or virtually. Books of Discovery likes to say, learning adventures start here. And they see that same spirit here on the Thinking Practitioner podcast, and they're proud to support our work, knowing we share the mission to bring the massage and bodywork community enlivening content that advances our profession. They invite you to check out their collection of e-textbooks and digital learning resources for pathology, kinesiology, anatomy, and physiology at booksofdiscovery.com. Thinking Practitioner listeners save 15% by entering Thinking at checkout on booksofdiscovery.com. Thanks to Andrew Beal and to Books of Discovery for their ongoing support. And Whitney, how are you doing?
Very well, sir. Good to talk to you again. We've been off for a few weeks as we dealt with various different things in different parts of the world here.
Yeah.
And so it's good to be back on stage with you again here. So welcome and good to see you again.
No,
yeah.
It's good to be here with you and getting back in the groove here. What are we going to talk about today?
Today, we're talking about the confusing and often fascinating world of thoracic outlet syndrome, actually.
So, confusion, fascination, and thoracic outlet. I love it.
Yeah. So,
and is there? Is there a handout?
There is a handout that's going to have some other great resources for you on this, and you will find that on our Thinking Practitioner website, as well as also on the Advanced Trainings website as well.
I'll put the URL in the notices that we send out too, so we'll make sure you got that.
Yes, perfectly. So you got some notes and some other resources there that we want to make sure you have access to for our discussion today. So, thoracic outlet syndrome. Anyway, we're going to take a jump dive into this and see what we can explore about this. It is a term that lots of manual therapists hear a good deal. And, it is interesting if you look at a lot of the literature that is written about thoracic outlet syndrome, they'll frequently say things like it's either one of the most underdiagnosed things that there is out there, or it's something that doesn't even exist. It really runs the gamut. Which is interesting when you see that in a lot of the medical literature, and that just illustrates some of the confusion, I think, around what this actually is.
No, that's really interesting. So there's either it exists everywhere and we're misdiagnosing, or it doesn't even exist at all.
Yeah. And that's part of the problem, is because it is so ill-defined, it makes it hard to nail down when is it really there and how do you really identify it. So we're going to look at some of those dilemmas today. One of the things that I found interesting about this, looking into some of the history of this term and the concepts around it, is having to do with anatomically where the term even comes from. So originally, thoracic outlet syndrome was seen predominantly as a vascular problem. And so there was a lot of emphasis on looking at especially subclavian artery as it exits the thoracic rib cage and makes its way over the top and then starts coming down the arm. And this is the region known as the thoracic outlet. And so that's where the condition got its name. But the vascular component, we're going to talk about this a little bit more down the road here, but the vascular component we've now learned is really very small in comparison to the neurological components of this particular condition, which seem to be a lot more affected by places where neural structures are exiting the cervical region. And some
the vascular component's small, or it's less common?
Yeah, less common. So yes, small is probably not a good word there. So less common. Thank you for that clarification.
Yeah, so you're saying that the vasculature is a problem in far fewer people than the other stuff, turns out.
Right, yeah. And so I've even seen a couple authors advocating the neurological components of this be more accurately referred to as a cervical outlet syndrome instead of thoracic, because it really has to do with the nerve roots coming out of the cervical region. So I don't think we'll see that anytime soon in terms of a change in terminology, but it is good to understand a little bit more about some of the anatomical features there to see,
No
where that's come
kidding. No
from.
kidding. That changes
Yeah.
things if I plug that into my thinking cap from being like a
Yeah.
way out of the thorax to being a cervical root possibility. Yeah.
Yeah. And this also helps illustrate some of the different variations in terminology problems associated with this, just because the thoracic outlet is kind of an ambiguous region. I even saw somebody talking about this one time saying, well, if you are a vascular surgeon or somebody who's looking at the vascular system, the area at the top of the rib cage is the thoracic outlet. But if
Mhm.
you are, for example, a respiratory physician, somebody who's focusing on the airway coming down
Mhm.
in there,
Mhm.
that's the thoracic inlet.
Mhm.
Uh, so again, some of those other confusion anatomical terms are a bit confusing for us in terms of defining that. So um, we'll try to do our best to adopt the most common facets of terminology there.
That's great. No, that's helpful.
Yeah. So as we look at this, one of the things that strikes me as being important in terms of a clarification are the divisions of what this, how the term is or the condition, we'll call it, is sort of divided. You will often see references to 3 different types of thoracic outlet syndrome,
Mm.
or sometimes it's divided into 2, vascular versus neurological.
Mhm.
And then the vascular may be divided into venous or arterial. So there's varying different statistics about this, but the neurological components of this condition tend to make up about 90% of the cases, whereas the vascular is much smaller, somewhere around 5% of those, with more being associated with venous problems and even fewer with arterial problems, which I find really interesting since thoracic outlet was originally viewed as a vascular disorder.
Right.
But now we're really seeing
So
it's much more
your reading
neurological.
shows you that maybe 9 cases out of 10, there's a primarily neurological component. And
Yeah.
I think just from memory, I don't trust my memory as much as yours, but I'm remembering 80%. But still, the vast majority are, pretty wide agreement that that's neurological as opposed to like cutting off the blood flow in most cases.
Yeah, and I think one of another important thing to consider is that it's quite likely in many situations that both of these things are going on. So it's not
Yes.
really appropriate to divide them up and say it's
All right.
just neurological and with no vascular
All
component.
right.
So that's
One more
why the
little
numbers
thing.
can be
Maybe this is less
fuzzy.
dividing too, but even the neurological ones, you could argue, could be microvasculature issues where the nerve is possibly distressed because it's not getting the hydration and the blood flow it needs.
Absolutely. So then is that neurological or is that vascular?
Mm.
If you got a neurological disorder caused by lack of blood flow, ischemia to the nerve structure itself, is that a vascular issue or is that a neurological issue, or is it both? So just know that there are those components and that we may be seeing any of them all the time. And for us, I just encourage people just treat them as if they're all involved,
Sure.
but know that we may see some different types of things occurring from different, types of those different variations. And we'll talk about those in just another minute as well.
In other words, maybe it doesn't affect treatment as much as it might, so that in some ways we can just treat them and see how that works out too. Is that what you-
That's interesting. So, the other thing that I want to emphasize here, and this is interesting if you look at the literature on thoracic outlet syndrome, it does not often go into as much detail on some of the variations of the neurological forms as it often does just make those distinctions about vascular, neurological,
Right.
or arterial and venous and neurological. But we have several different variations on the neurological components too that have some important anatomical distinctions. So
Tell me about that.
there's essentially 4 of these variations that we usually ascribe to. Sometimes the first 2 are considered similar together, but the first of those variations has to do with an anatomical anomaly called a cervical rib. And a cervical, it's really important to remember that there's all kinds of anatomical variations from person to person with lots of stuff that we don't see in the anatomy books that are still moderately common. And a cervical rib, I believe the last time I looked and saw statistics on this, happens in roughly I think it was 1 to 3% of the population or something like that. So
I looked this up a couple
not
of years ago. What I found said 1 in 200, so 0.5%, but somewhere.
1 in 10. Okay, yeah. So a small number, but if you kind of think about that, out of every 100 to 200 clients you see,
Mm-hmm.
one of them might have a cervical rib. So I mean, after a while, it's not as uncommon as you might think. But what is it? The question.
Well,
So,
hey, wait a minute.
um,
Our last episode had like 2,000 downloads. So that means there's like 10 people listening to this podcast that have cervical ribs. You could be one of
How
them.
about there you go. Yeah, so, okay, yeah, could be one of them. I remember when I first learned about the presence of cervical ribs, I was thinking about the number of people that I had worked on previously that seemed to have these rock hard scalene muscles right in their anterior neck region, and I could not get them to relax no matter what I did. I was rubbing the crap out of them, and they just wouldn't relax. And I got thinking after a while, hey, I was probably rubbing on their cervical rib.
Yeah.
So anyway, back to what is it? The cervical rib is it's an anatomical anomaly that is an extension of the C7 transverse process, and it sort of curls around on the side of the neck and comes down and has a fibrous attachment, usually to the first rib. So it makes an extra sort of curved rib around the top of there, and then when it is present, the brachial plexus and the neurological structures are draped across the top of that extra bony structure there, and that they can kind of get bowstrung across the top of that cervical rib in this variation of thoracic outlet syndrome, and that's what usually sets off those symptoms for individuals.
Can I make
So,
a little distinction there? I'm
of course,
sorry to be like your editor today, jumping.
I like it.
Just because there is a higher incidence of brachial and cervical plexus symptoms in people with cervical ribs. But just because you have one doesn't mean you necessarily are going to have problems too.
Very important distinction, yeah. And I would also comment, just because you have a cervical rib and you have neurological symptoms doesn't mean you have to have that rib taken out.
There you go.
Because that is a frequent treatment is surgical removal of the excess surgical removal of the cervical rib.
Yeah.
But you've had it your whole life, and you've been able to get along without having the surgery for a long time. So maybe there's other strategies and ways to do that. So
Most
yes,
cervical
good, important.
ribs, yeah, most cervical ribs are asymptomatic too.
Yeah. So just know it could be a factor. That is a possibility. And if it's there, we'll try to work with it in a variety of different ways that we can. So, so that is the first variation of the neurological group. The second one being compression of the brachial plexus or neurological structures between the anterior middle scalene muscles. And this was, I know, described by a number of different people, and it was listed. I remember seeing it in Janet Travell's book many, many years ago as their Latin term scalenus anticus syndrome, or the anterior scalene syndrome. So a compression of those neural structures between the anterior middle scalene muscles in the cervical region. Now, this would be the area that we refer to as the cervical outlet. So that would make sense for those two variations to be the neurological cervical outlet variations. But again, we probably won't hear that term mentioned that way for a while. So, and as you course a little bit farther down the pathway of those major nerve trunks of the brachial plexus, the third variation is the costoclavicular, what's called costoclavicular syndrome in many instances. This is compression of those structures between the clavicle and the first rib. So that is right near the true thoracic outlet, but it actually isn't the nerves coming out of the thoracic outlet. It's just nearby there. So compression of those between clavicle and first rib.
Wait a minute. It's not the neurovascular bundle you're saying getting compressed?
No, it is the neurovascular bundle. It's just, it's not coming out of the thoracic rib cage. Just keep in mind,
It's already, that bundle's already out of the quote inlet or outlet.
Yeah.
It's already out into the periphery of the body a little bit, far enough as the clavicle, and that's where you might get caught up.
Yeah, exactly. Okay. And then our fourth of those neurological variations, often referred to as pectoralis minor syndrome. This is compression of that group of structures underneath the pectoralis minor muscle against the upper rib cage. And this is frequently referred to as pectoralis minor syndrome. So those are the four neurological variations, and then we have the vascular variations as well.
Yeah. Now, just a little footnote on the vascular stuff. A lot of PTs are taught, Well, there's a pretty good body of evidence that physical interventions can help the neurogenic kind, either exercise or stretching or manual therapy. There's a bunch of massage therapy research into this even. But a lot of PTs are taught because there isn't much evidence of success around the vascular, truly vascular ones, that there are a lot of PTs are thought refer to surgery if it's vascular.
Mhm.
Now, I don't know if I'd be that fatalistic about it, but
Yeah.
we can do a whole lot around all four of those neurogenic variations you described, Whitney.
Yeah, I think so. I think there's a lot of possibilities there, and the more you understand those different possibilities, and we're going to talk about this a little bit more as we look at how to evaluate some of these things. But it's not always easy to figure out which one of those is really the primary problem, or if there is just one. Might there be more than one, which is frequently the case. Um,
I know you and I are kind of layering in our different ideas here. What do you think about me giving a movement example for each one of those? Is that too early in our discussion?
no, let's do that since that'll be fresh in our mind. We just talked about
Yeah.
those variations, so let's
So,
do
okay,
that.
so like as a little review, the cervical rib, and I think you have that noted there, Whitney, is the true neurogenic
Yeah.
thoracic outlet. That's another way to describe it. For a cervical rib, boy, I actually don't have a really good test for that, but brachial plexus might be side bending, side flexion of the neck, perhaps.
hmm
What do you think, Whitney? Would that be a
Yeah.
movement that would light that one up?
That would be most likely. Now, again, that's going to do that more if your arm is out to the side where
Yeah,
the rest
that's
of the major part of the neural structures down the upper extremity are already pulled taut from their lower end, and then you pull them
thank you.
taut from the upper end across there.
Thank you. Whitney maybe could see me
Yeah,
do that on our camera, but that is a part of
right.
that one. Let's say stretch your arm out and tilt your head away from that. If that makes your
Mhm.
hand go numb or you get some of those tingling symptoms and stuff, maybe it's neurogenic, maybe cervical rib, cervical nerve root. Again, these are not diagnostics. I should just put in that huge disclaimer too. These are like working hypotheses for where you might start your work. These are
Mhm.
good guesses for body workers kind of things.
Yeah.
For the second type, anterior scalene syndrome, that one's probably going to light up the most with head rotation, head neck rotation, looking away because of the scissoring effect of the anterior medial scalenes, where they just kind of little triangle there closes around those nerves when you turn your head. And again, it's going to be much more sensitized if you stretch your arm out on the side that you're turning away from. Would you agree?
And I would, and I want to just point out here too the importance in what you're describing and illustrating there is a really important, valuable lesson for people about understanding what the term is often referred to as neurodynamics,
Oh,
which is the sort of biomechanics of the nerves in different positions of the body or the extremities or whatever. And you can take a standard movement procedure that should stress a certain area, like you were talking about for the anterior scalene muscles, turning your head slightly and possibly even a little bit of lateral flexion.
uh-huh.
If your arm is in neutral, you may not feel anything.
Mm,
But if your arm is pulled out to the side, as we were talking about, now you're stretching the whole neural structures in there, and that makes that particular evaluation process more sensitive. And that's actually a really important clinical tool because you can use that to determine sometimes a level of severity. Like you start in a really neutral position that wouldn't really flare something up, and then you have them bring that arm out to the side and pull it a little bit more. And if that really lights the symptoms up, okay, this one's pretty sensitive here to those just a little bit of extra movements.
that's good. No, thank you. And I'm suddenly very aware that I'm kind of mucking about in your domain of expertise here, and that there's so many very specific orthopedic tests that are done in precise ways to try to ensure their sensitivity, or at least up their sensitivity and specificity. I'm talking about really rough, quick movement guesses that you might do as a body worker.
Yeah. Yeah. And I think those, to be quite honest, I think those are often more valuable than some of the orthopedic tests that have been written about and published in all the books a lot of times because everybody is an individual. And when we can tweak those little movement patterns a little bit and see what is it for you
Mm,
what's the movement for you? Because the other thing, remember, everybody's structure of their whole skeletal and musculoskeletal system can vary quite a bit in terms of where is that a narrow pathway? Is that a wide open pathway in that particular area? Like maybe
mm.
they got a really narrow area between the scalene muscles, but a really wide space between the clavicle and first rib, and somebody else has got the reverse. And so just the application of those tests in a vacuum without considering all those other things is oftentimes, I think, where people get led astray in putting way too much emphasis on some of them.
That's great. So
Yeah.
we had a side bending the head for neurogenic. We had turning laterally flexing, stretching the arm for anterior scaling. For the costoclavicular, your third type, the classic test there is like weight carrying, like carrying a heavy suitcase. If you can imagine that, that would pull the clavicle down onto the first rib there and might irritate the neurovascular bundle there. Or it's forced inhalation. A really big inhalation could billow the rib out from underneath the space there, the neurovascular space, and compress it that way.
Yeah.
There's a lot of overlap here, because of that, scalenes are also activated in forced inhalation. So there's, these aren't precise anatomical diagnostics as much as, again, a way to get a working hypothesis.
Yeah. Yeah.
And then,
lastly,
for pectoralis minor involvement, there could be a number of things there. And when in our longer thoracic outlet class, we teach it as anything in that region, especially anything that attaches to the coracoid process there, with pec minor being a prime suspect, but there's also coracobrachialis, there's also short head of the biceps. Anything in there could be part of what is essentially crowding or binding to that neurovascular bundle as it kind of loops around the pulley of the coracoid process. So the coracoid process is that little beak-like bony projection that comes forward from the scapula to the front of your body. Pec minor attaches there. So anything that actually activates pec minor, if that reproduces the symptoms, it's a good clue that you got a zone of sensitivity.
Yeah. And an interesting little one about that particular one with the pectoralis minor and some other neurological involvements that shows the importance of understanding some things about neurodynamics is if you can envision, there's some really good illustrations. And again, I remember one in particular that really just made such an impression on me when I first saw this was also in Janet Travell's Myofascial Pain and Dysfunction book, an anatomical image of the arm held in abduction. And you see how those nerves
raise your hand
go,
if you know what arm abduction is.
Yeah, so arm all the way, shoulder all the way out to the side as if you're like putting your hand up on top of your head.
Yeah.
And that brachial plexus goes down, loops under the pectoralis minor, and then has to come back up almost at a 180-degree turn.
That's right.
To come back up in there. And that's often when you have a pectoralis minor syndrome, lifting that arm up over your head is the kind of thing that will exacerbate those symptoms. Now, the interesting thing about this from a neurodynamic, perspective, when we're trying to discriminate between different types of symptoms, that very same maneuver is often used to evaluate the likelihood of cervical nerve root involvement. Because if you have symptoms down your upper extremity that are neurological in nature, and you do that movement and those symptoms get better, meaning they dissipate, that's often indicative of some type of nerve root involvement or something. Because if you don't have problems in the thoracic outlet region under the pec minor, you are bringing that whole upper extremity neural structure closer to the neck. So you're really slackening the whole thing.
Yeah.
And so that's oftentimes exactly. Yeah. So it's fascinating. Like it makes it worse in one situation and makes it better in another situation. So helpful to be able to make some of those distinctions.
No, that is super important. And then the other thing to keep in mind for any of these is that if you can reproduce the symptoms with palpation, with pressure, gentle pressure with your hands, that's a really clear sign you're onto something. So if you can gently press around the coracoid process and someone feels tingling on their arm, bingo, you got a place where that neurovascular, the nerves are sensitized. And similar around the scalene zone too.
And that'll be a really important one when we talk a little bit about treatment methods too, because it is really important when treating neurological problems to not do things that make it worse. So, and we got to remember there's a couple places here in this thoracic outlet region, especially the area between the scalene muscles, where those nerves are really superficial and they're close to the surface. So it can be easy to irritate them with your palpatory explorations or your treatment as well.
Well, and then there's the question like, isn't everybody sensitive? Like in your scalenes, if you go digging around in there, you're going to get some numbness on all of us. Yeah. So it's I guess it's a question. I don't know. You got an answer for that one, Whitney? Before I try mine.
No, I would say, go ahead and tell me what you're gonna.
I was gonna say, keep that in mind. That just because you can provoke symptoms doesn't mean there's a pathology. Also, but for sure, it's the level of sensitivity. And is it just like what they always feel? That's a pretty good clue. You're onto something relevant. And how much pressure, all that kind of stuff. If it's just really a little bit of touch, a little bit of pressure, that's pretty sensitive.
Yeah. Just something came to mind here. When I was a kid, I don't know, probably 8 or 9 years old or something like that. I used to wrestle with my dad all the time, and I remember I had seen some kind of like wrestling show or something
Uh-oh.
like that, where some guy grabbed this other guy right over the top of their clavicle and just like really held onto it really firmly, and the guy passed out or something like that. And so I decided I was going
Uh-huh.
to imitate this little thing, grabbed my dad's shoulder neck and just dug my fingers in it. He was laughing because we were playing a lot, but then I made his arm go numb for like 2 weeks. And
Yeah.
I learned, figured out later on, well, I probably did some intermittent damage to the
You
brachial
probably
plexus in there.
bruised his brachial
A little
plexus
too much
there. Yeah.
pressure. So,
Right.
that's not a treatment I advocate any longer.
Okay.
Yeah.
Good.
Yeah.
Good deal. Well, and then there's like the double crush idea. I mean, we're going to
Tell us
talk
about
about,
that.
well,
Yeah.
we're
Double
going to talk about
crushing.
controversies, but
Yeah.
the idea that in a number of people, you have more than one spot, more than one
Mhm.
place where that nerve track is unhappy. And according to Joe Gibson, who knows a whole lot about this stuff, she says that somewhere between 2/3 and 3/4 of scaling entrapments also have pectoralis minor compression, so that you
Mhm.
end up with it in multiple spots along the pathway.
Yeah. And this is another good reason to sort of, I mean, it may sound a little glib, perhaps, but I always tell everybody, treat this person as if they all exist, because
Mm.
um, most of the time there's a likelihood for multiple locations of neural entrapment or something like that, and treat them as if all of those things are there and address all of them, because they could all be a potential factor. And there aren't really definitive methods to exclusively say this one is here, but this one's not,
Right.
So
Right.
there's not that degree of exclusivity that we have for our evaluation procedures.
Mm-hmm.
It is helpful to be able to identify some things differently if we can. Just know it's not rocket science.
Yep. Well, so we've been talking about a whole bunch. Is it time to ask the question, is it even a thing?
Well, let's do. Yeah. So we talked about what we think it is from those people that think there's a lot more of it than there is talked about that. Well, what about it not being a thing?
Oh, I assume it's a thing.
Yeah.
That was my softball to you.
Yeah.
I think
Well,
it's a thing.
here's why I think that comes about in terms of the literature saying like they don't even think it's a thing. It's because it's so poorly defined.
Uh,
And people have such a difficult time identifying what's going on with them. And this is where I'm going to make a real, I'll just put a caveat out here, blatantly biased statement that I think a lot of the practitioners who treat musculoskeletal disorders are not thorough in their musculoskeletal evaluation process, and that's why they don't find it. So that's why I think there's some dilemma about how accurate that is. And that doesn't mean necessarily, not just their physical examination process. A lot of it is even delving into a history deep enough to really identify, movements that irritate, movements that aggravate, movements that relieve, all those kinds of things that are
yes.
important key factors to help us identify things that I think so many of our practitioners are so pinched for time with each
Mm,
patient, they don't go into the level of detail to pull that kind of stuff out. So you're going to miss some of those. You're going to miss a lot of
pinched
them, actually.
pinched for time. I like that.
Yeah.
Or not unclear about their domain or their focus. Do I need to give this
Mhm.
client a full body session? Are they wanting to relax? Or am I giving extra attention to this numbness and tingling in their hand they just told me about?
Yeah.
Those kind of
Yeah.
questions. So, I mean, there's a
So,
bigger question there too about what makes something a thing
mhm.
that I'm going to try to
Yeah.
stay out of. But that's, you, in terms of it being a precise diagnosis, no, I can totally go there on questioning that. Is it
Mhm.
a therapeutic narrative that can give some usefully strategic pointers? Yeah, in that case, it's a thing for me.
Yeah, absolutely. And another important thing that I want to just touch on here anatomically that um, often doesn't get addressed as much, but is a valuable one for people. Like when people come in and say, "I've got pins and needles or tingling in my hand,"
Tell me.
lots of individuals immediately their mind just jumps to, okay, this is a carpal tunnel issue or
Yeah.
something like that, which because it's the popular one that everybody hears lots about. But an important distinction with thoracic outlet syndrome is the vast majority, and not all of them certainly, but the vast majority of those cases do tend to involve the ulnar nerve distribution much more so than the other major nerves down the upper extremity, either median or radial nerve distributions. And that's because the nerve roots that come off the lower portion of the
Wait a
brachial
minute,
plexus.
don't tell us.
Yeah.
Let's make sure that I know what that means. Like,
All right.
so then you're talking about numbness that would be in my little and ring finger, say, as opposed to thumb and pointer finger.
Yes, thank you for the clarification there. Yeah, so outside edge of your hand, last two fingers, pinky finger and ring finger,
That's ulnar
is the
nerve.
sensory
Yeah.
distribution of the ulnar nerve. Yeah.
Great.
And so across the rest of the palm, the other two fingers and the thumb on the palm side are predominantly the median nerve distribution. And then it wraps a little bit around the thumb, and the radial nerve is on the back side of the hand.
And just to diverge further from what you're saying, the median nerve is responsible for a lot of what people call carpal tunnel syndromes, or at least it's thought to be. And so those tend to be focused more or less thumb and forefinger. But now you're saying somebody that comes into my practice, tingling in my hand, and when I ask or investigate, it's little finger and ring finger. Aha, ulnar nerve.
Right. Not carpal tunnel syndrome. So, and it could be, there's a number of different potential locations of ulnar nerve entrapment throughout the upper extremity, which is a great topic for us to tackle one day, that we'll probably get back to. But there does tend to be with the neurological thoracic outlet variations tend to have a lot more symptoms in ulnar nerve distribution than in the other two. And that mainly has to do with the architecture of the brachial plexus.
Okay, because like the median nerve also arises from those same roots, right?
It does. More fibers to the ulnar nerve from the lower portions of the brachial plexus, the lower nerve roots.
And so that's why if it's ulnar nerve, it's more likely to be thoracic outlet because it's typically those lower segments that are involved more.
Yes, because those lower segments, if you think about it, those segments that are coming off the last cervical vertebra are the ones that are going to be most inferior in the group or the bundle of nerves that make up that plexus. And so they're going to be the ones that are going to be dragged across that cervical rib the most. They're also going to be the ones dragged across the upper rib the most, pinched between the clavicle and first rib. And they tend to lie against the upper rib cage with more pressure than the rest of the brachial plexus. So it does tend to get those variations of the lower brachial plexus more involved.
Fascinating. That's really cool. So they're starting lower. They might have to do a sharper bend to get around those things in the thoracic outlet.
Exactly. Yeah.
And then if I just put my arm out to the side with my thumb up, like a dermal tumble position, I don't know if there's a factor or not, but then I raise my hand over my head. It's like on a track, running around the track. The outer lane has to go further. I don't know if that's why those axons get irritated more, perhaps, but they're even in the axilla, even in the pec minor, there's theoretically a slightly longer pathway they have to take.
Right. And then if you think about that position where you're frequently reaching up like you just did, and people can't see on your camera, but you were reaching up towards your head as if you were scratching your head, your elbow is flexed at that point, and there's a lot of tension on the ulnar nerve as it goes through the cubital tunnel, and the cubital tunnel shrinks and gets smaller in elbow flexion as well. So all of this is back to your double crush point. You've got multiple locations along there where you might be potentially irritating that ulnar nerve more significantly.
That's so cool.
So that's why it's important for us to really zero in, I think, on a lot of those symptoms from what our clients are telling us and experiencing, because it really helps us narrow down where we want to try to focus, I think.
Yeah.
Yeah.
Well, I got a couple miscellaneous trivia points that
Let's hit them.
And then maybe we'll do a stretch or two. I'm going to for sure put some hands-on techniques in the handout. There'll be an outline of what Whitney and I have talked about. And I realized what the URL will be, so I'll go ahead and announce it here and at the end too. The URL is going to be a-t.tv/ttp-tos. You got that right? a-t.tv/ttp-tos. It's going to be the notes. Don't worry about it.
Sounds like Morse code.
It is.
The dot.
Forget it. Go to the show notes. You'll get it there. But anyway, the trivia points. 71% of cases tend to be female of thoracic outlet. average number of physicians visited for what turns out to be a thoracic outlet problem is 6. People seek a
Hey,
lot of treatment before they get it figured out. Go ahead, buddy.
can I back up a moment here? Do you have any input or rationale ideas on why the very skewed percentage toward female instances with this?
It's such a good question, and it's so true for so many conditions, isn't it?
Mhm.
I don't. Like,
Mhm.
in some conditions, there's clear anatomical differences between the gender
Yeah.
sexes, but I don't know the rationale for this in females, why it's
Okay.
on females. No, I
Yep.
don't. Uh, So yeah, a lot of visits to doctors before it gets diagnosed. Average length of time before it gets diagnosed, 5 years. So that's the
Wow.
idea that a lot of people can't get it figured out, which leads people to even
Mm.
wonder, is it a useful medical diagnosis? Because
Yeah.
there's a lot of those people end up with symptoms in their head, like headaches or chest pains or chest tightness, shoulder issues. And there's stories of lots of unsuccessful surgeries that eventually, the issue got resolved when they got their thoracic outlet symptoms addressed.
Yeah.
So it's, it can be a challenging problem for someone to have, and just a lot of understanding and sympathy, as well as a big open mind around that too, because it's really hard sometimes to pin it down as this is that. It's really a case of what activities on the patient's part or client's part, what treatments we do seem to help.
Yeah.
There's
Um,
in most sorry, go ahead, Whitney.
No, go ahead and finish that point because I want to come back to something because I was just realizing in our discussion we have emphasized and talked a lot about symptoms from the neurological variants, and I want to make sure we just at least touch base on a few of the things to watch for in those other
And the vascular.
vascular ones as well. So go ahead
Well,
and
no,
finish up what we're talking about here.
after you, sir. That's you've
Okay.
given that such a good lead in. Let's hear what that would be.
So yeah, just keep in mind with the vascular variants that we're likely to see a lot of those types of things that are relatively common with other vascular problems. For example, in an arterial involved one, you might see ischemia because there's lack of blood flow down the upper extremity. So there's going to be possibly some ischemia associated with there may be
How would I see that as a practitioner? How would I know?
so, a person's limb, maybe looking at the comparison of their hands, one hand to each other,
Hand
one looks a
color.
lot wider,
Oh,
more
swelling.
pale than the
Yeah.
other.
Oh,
Yeah,
oh,
so
oh.
color
Mhm.
color evaluation. And then that also goes over to the venous side as well, because if there is a venous blockage in there, that means there's a blockage of return. We may see more edema or possibly, a little bit darker coloration to their limbs because of the lack of venous return there. So you're getting an accumulation or blockage of venous flow on the upper extremity. So
Mhm.
those could be certain indicators of vascular problems in there. There's pain that may result just simply from a lack of appropriate vascular supply to muscles can be a factor in there. Other types of vasomotor indications, with sometimes things having to do with the little hairs on your skin
Yeah.
that are not acting the same on side to side. Those are kinds of little things that could be factors. So these
I
are
hate
some of
it
the other
when
things to.
hairs don't act the same side to side. I hate that.
I know, yeah, it's like behave, yeah, get them to behave correctly. So,
So you're saying like
yeah,
you get goosebumps on one side, but not the other. That's really
pseudomotor responses there, and so, clients expressing things like a sensation of fullness or thickness or some kind of
Mhm.
sorts of ambiguous descriptions of they just don't feel the same on each side that might be indicative of improper vascular movements in there. So those are some other things. I just want to make sure we don't forget to look at when we're talking about those different variations.
Sausage fingers. I got my sausage fingers again.
Yes. Uh-huh. Right.
That can
Yeah.
be some other stuff too, but that's the that can be a vascular thing for sure.
Right. Yeah.
Okay, great. That's helpful. And then so, um, yeah, I got a bunch of trivia there, but I don't really. It's trivial, that stuff.
Mm.
Should we do a movement or two for ourselves?
Let's do.
Yeah.
Yeah. Let's talk about movement and what do we do about this kind of stuff.
If
So
in
some
doubt,
movement things
move.
and some
Right. So
treatment
what do
things.
we? The
Yeah.
treatment stuff, I'm not gonna try to explain over the podcast. I'm just gonna put a picture
Yeah.
in the handout and refer you to
Yeah.
some of Whitney's great stuff and our courses as well. But I'll put some specific techniques for the scalenes in the handout. But for something you can do for yourself or you can help your clients with side stretches, just take a hold of the bottom of your chair on one side. Let's say it's the affected side. Hold on to the underside of the chair. Yeah. And then tilt your head away from that side. So you're going to laterally flex the neck away from that side. Move your head backwards. So like reach for the back of the room with the back of your head and then look up. So if that's going to be stretching a lot of stuff, including your scalenes, excluding the scalenes right around the zone where that thoracic outlet goes through. So be nice to yourself. It's making my voice a little bit hoarse.
Yeah.
Right there. Yeah. Be nice to yourself and breathe and relax. And then it's about to come out of that too.
Do you have an advocation for length of time on holding these versus doing shorter duration stretches? And we got into a discussion on another thing about this recently. What's your sort of go-to on stretching durations for those kind of things?
Oh boy, I get to ask that all the time, and that is the art. It's like there probably is in the classical parameter that's defined as what is it, three sets of 10 or whatever. They pick some parameter they guess is going to probably be good for the research. Do the research, and then everyone adopts that as the treatment standard. The real answer is you want to desensitize things. Mm-hmm. I'm doing just enough that it gets the brain's attention, but not so much that it upsets my brain.
Yeah.
So it might be just a couple seconds or even more than duration, perhaps at that level is how intensely I do it. So let's go ahead and do the other side. So you're going to hold on to your chair, tilt your head now to the other side, holding on with the other hand, tilting away to the other side, move your head backwards, look up, breathe, and you get to come out of it when you've had enough, but you also get to decide how much intensity. So you're getting just enough intensity to get your brain's attention, but not so much to make your brain upset. And then you come out of it and you're going to repeat that. Yeah, I think it's valuable to repeat. And I think it's valuable to repeat it a couple times a day.
Yeah.
But if you want to, it's more important to teach people how not to overdo it. Because if you have it's like say thoracic outlet symptoms or that tingling or numbness down that side of your hand, you could definitely do that in a way that kind of feels good. And you think, oh, the more I stretch it, the better. No.
Yeah.
It's more like the more your brain gets used to it, the more your brain relaxes around it, or perhaps the more hydration you stimulate in there, who knows, then the better. So it's like a gentle tickling more than an aggressive stretching of that symptom.
Yeah. So sort of physiologically, we want to keep in mind when you're doing these kinds of things that you're trying to encourage some increased stretch tolerance to those contractile elements in there, but you're not trying to stretch the nerves. And that's sort of the important thing. The nerves don't really like to be stretched. And so we're trying to get mobility in those tissues that need some enhanced mobility and freedom of movement, but not do those things that increase neural irritability. Because another important factor to remember with nerve injuries is they are notoriously slow to heal. So if you've had this for a long time, it might take quite a while to get some restoration of good movement and decrease of symptoms in there.
Oh, those are important points. And I can't help but quibble a little bit. But you tell me, you said nerves don't like to be stretched. That's such an important point to tell our students who are used to stretching things like a big joint stretch or something. But I would wonder if you would agree with me if I refine it to say that nerves like to be stretched within a certain amount of range, a normal range. Like the sciatic nerve turns out to lengthen 5 inches just along its normal case of range. It actually likes that. But if it's asked to be stretched more than it's used to, that makes it pretty unhappy.
Yeah, I'd say that's an important clarification. I'd also make the clarification, if we can, between stretching them and mobilizing them in some instances too. It's really important to make sure nerves are mobile, and sometimes that might involve applying tensile loads to them to make sure that they are fully mobile. But yes, and when we talk about stretching within their safe parameters, that's a good distinction. So thanks for that.
My best metaphor for myself, and please forgive me for this, is when I was a kid, our backyard, we would irrigate it with flood water, and all the earthworms would come crawling up out of their holes. All right. So there's a bunch of earthworms kind of gasping for breath, lying half out of their holes. And we would go gather them up because they were so cool. I'm talking like 5 years old. Mm-hmm. If you pull the earthworm too quickly, they're unhappy. Bad things happen. But if you go really slow with those worms, you actually have a pet. You have a new friend.
Mm-hmm. Yeah.
So it's like that with nerves. Nerves like to be coaxed to glide
Yeah.
and move. If you're just tugging on them, don't do that.
Yes. Yeah. Good distinction there. Yep.
All right, so pec
So
minor, should we talk about that?
yeah,
Stuff to
for
do
sure.
for if there's some pec minor symptoms, like raising the hand over the head, the abduction evokes the symptoms. There's some interesting research, Whitney, and in fact, the reference I had in my handwritten notes there is Lowe et al., 2011, that he and his
Some
group,
bozo there.
Lowe et al. In 2011 apparently did some work around the efficacy of
Yeah.
different physical treatments, and they found that the door frame stretch, like putting your hands on a door frame and leaning into it, made the biggest change in length of the pectoralis minor out of all
Yeah.
the different physical therapy treatments they were studying. But a lot of people find that's almost too much, and that you can get a backlash by overstretching it that way too. So some PTs are teaching more of a corner stretch, where you walk into the corner, put your hands on the two opposing walls at about shoulder distance, and gently lean into the corner as a very gentle kind of pec minor stretch.
Yeah. And I would also call attention to the fact that many of these stretch positions and movements that we're advocating are very similar to many of the positions that are used in a lot of our evaluation procedures. And what we're trying to do is we're trying to move that point farther down the road of what you can do in the direction of what is it that causes some degree of irritability. So especially with neural problems, you know, a lot of times with the what we call a muscular stretch, you can tell somebody, oh, go ahead and stretch into this. Like you can say, oh yeah, just breathe when you feel that discomfort. Go ahead and breathe into the discomfort of the stretch. And this is the point at which that nerve may not be so happy about pushing that degree of the envelope somewhat, but we are going in that direction to move it more, gradually increase that capability for it to move into those directions.
Capability for it to move, and then also the capability of the brain to tolerate that or even enjoy it.
Yes.
Like David Butler's thing, like tell a joke there, get them to position and tell them a joke. Just recontextualize their neurological experience.
I like that.
Yeah. Go ahead.
I'm terrible at remembering jokes, so I'm probably not going to be, you know, my clients would probably say, like, you already told me that joke. That was a foot joke, you know.
All right.
Yes,
You're like
trying to work on my brachial plexus.
you need your brachial plexus specific jokes, pec minor jokes, something like that.
Yeah, right.
So we got the leaning into the corner. Now here's an interesting point. You said it can be like the hands-on assessments. On the table, a fairly thick roll towel or a small round bolster or something under somebody's spine. So your client's supine, they're face up on the table. There's a bolster or rolled up towel under their spine. That allows the shoulders to fall back onto the table. Picture that. That's a great position to essentially load the pectoralis minors. And again, if it provokes symptoms, go easy around it. But if it just starts to light them up a little bit, have someone breathe and relax a little bit, again, just to start to mobilize and reset the reactions to those kind of sensations.
Yeah, and I would also call attention to this. What you're describing there is a really good one because I know I've had a number of people who have these types of symptoms as an upper extremity, shoulder / cervical region, brachial plexus problem, who say once you put them over in a position supine on a flat massage table like that, start getting symptoms down their arm, and all it takes is the little rolled towel. Just moving it just a little bit to try to find what is the position that's going to slacken that brachial plexus a little bit. So that's a nice little trick that can help decrease those symptoms for all kinds of things in different positions.
So that's important. You're talking about actually relieving the symptom or helping someone be more comfortable on the table. That's a important skill too. I was talking about provoking the symptom very gently with a towel, draping around the towel. But again, you don't want to leave someone there too much, just like you don't want to be doing that leaning into the corner stretch too long too. If I forgot to tell you to stop that and come back to your podcast.
Right. Yeah.
Okay. So then one important distinction too along these lines is it was Rosa et al. In 2017. They studied this pec minor stretch thing really carefully and said after an intensive regimen of 6 weeks of stretching, there was actually no change in its length. No change in its length. So probably the effects we're getting, this fits with a lot of things we're learning about, stretching and biomechanics in general, is that, the effects might not come from, say, physical or measurable changes in, say, the length of the structures involved, but they do have an effect on pain. And maybe it is the tolerance of the stretch. Maybe it's getting used to those movements. Maybe it's reminding your brain that those are okay. Maybe it's hydration, descending modulation. There's lots of ways we're explaining the effects. But really invite you to tease out that point of view in your mind that says, I got to physically stretch this like a bunch of taffy and hold it until it's going to stay there.
Yeah.
That's probably not what's happening. And there's probably even more useful therapeutic narratives you could be imagining as you work.
Yeah. And pectoralis minor is one of those, one of a few muscles in the body. I always found this to be interesting that when we talk about, we talked about this in our stretching episode, which I can't remember the number of it, but it was some time ago when we got into talking about what is really happening with stretching tissues. But, when we talk about stretching muscles in different parts of the body, pec minor is one that's very difficult to do that at all. It's not surprising to me in this particular study, as you mentioned, that they didn't find any change in the resting length of pec minor, because it's actually really hard to pull the coracoid process away from the ribs far enough to really cause a significant length change in that muscle.
Yes.
And to me, I think that's one of the reasons why we see so much chronic hypertonicity in that pec minor, is because you just don't have the available range of motion to do that. And, I would also make note to people to pay attention again here to anatomical things, because I see people doing things where they're advocating pectoralis minor stretching all the time, where they've got their client's arm, raised up over their head and they're abducting and they're bringing their arm up all around and everything.
Is that the one where you stand
But
on the
remember,
elbow?
what's that?
Is that the one where you stand on your client's elbow?
Could be. Yeah, that could be. But remembering that the pectoralis minor does not attach to the humerus at all. So, you're not really extending the length of that pectoralis minor, maybe a little bit with scapular movement, but not much. You're really going to get a way better stretch on that pec minor by lifting your shoulder up towards your ear and elevating the whole shoulder girdle, because that's what will pull the coracoid process away from the ribs more significantly. So,
nice.
Just a factor to consider there.
No, nice. So then we can think about the pec minus being the unshrug muscle. It's the one that pulls the shoulders down out of the ears.
Yeah.
So that might be just a great little pec minor wake up. It's like shrug and unshrug, pull your shoulders down. That's pec minor being both eccentrically and concentrically engaged. And I'll put in some techniques, hands-on techniques. They do not involve standing on your client's elbow or whatever. That was a joke. Please no hate mail about that.
I hope everybody understands that.
I know. But I will put some gentle techniques for working with pec minor there that in our narrative, at least, leverage, say, Golgi tendon responses. So they're looking at the neurological control over the resting tone of that pec minor, as opposed to trying to, say, physiologically lengthen its connective tissue. We're neurologically relaxing its resting tone. At least in that point of view.
Yeah, good. Well, we've hit on a lot of stuff, so we'll put some treatment things in that handout to carry this on to the next little bit here. So anything else you want to wrap up with in summary here about what we've
that's good. We covered a lot. So let's wrap it up. I think for the one point, if I was going to pull it up for summary, is the provocation piece. That's how we know we're on track. If we can do a movement or find a place to work or have a client position that gently, being the big key, provokes some of that sensation, bingo, we found something relevant. And then we work with softening around that, not getting more aggressive, not trying to ratchet up to the next level of intensity, but actually ratchet it back to a level when someone can actually physically, autonomically, start to relax around it. So how about you? That was my summary point. Provoke, but wisely, sensitively. And the point there is to change the reaction around what you're provoking or give you ideas to work on. How about you? How would you summarize, Whitney?
Yeah, so one of the things that I just wanted to kind of make sure everybody kind of thinks about is when we're talking about these thoracic outlet syndromes, they are often highly complex and highly variable and lots of different pieces of the puzzle going on. So make sure to really look at this whole big picture, put a lot of emphasis on, history, asking really good, thorough questions with people, really delving into this, and avoid the temptation to really zero in on these special orthopedic tests that are oftentimes designed that a lot of people say, well, here's how you find out if the person's got thoracic outlet. You do the Adson maneuver or the right abduction test. And I think we tend to get off track by zeroing in too specifically on some of those kinds of things and missing the bigger picture. Like a lot of the movements, Till, that you talked about in the beginning of getting people to go through these various different movements, find out what irritates it, what makes it better, that kind of thing. Those are real key factors for us.
Awesome. Thank you.
Yeah.
Yeah, looking at that big picture and you're not getting so detail focused that you lose that big picture. And joints, I'm just making me think, I'm sorry, I know I've already done a summary, but this makes me think too, the other issues in the body, like classically rotator cuff sensitivity, can coincide with thoracic outlet symptoms as you protect the different movements that can set up your scapula to be in a position or a movement pattern where it gets more irritated too. So keep the picture in mind there as well.
Yeah. Great. So lots of interesting and fascinating things to dive into with the thoracic outlet syndrome. And we'll explore some of these things. Maybe we'll venture down the upper extremity, look at some of these other neural entrapment problems that we talked about in other areas too, as we look at a lot of other potential problems that may also, and this is one of the things we didn't get into, can frequently be misunderstood to be or misidentified as a thoracic outlet syndrome when it's all kinds of other things
or
as well.
Hypermobility, that whole question on hypermobility to talk about like a rabbit hole, because there is some evidence that there's I think it's like 25%, there's a crossover with people that have perhaps some sort of hypermobility thing going on. That's always a puzzle in manual therapy. How do we work with somebody who's, quote, hypermobile? Is that really a thing, so to say?
Good. Well, we'd like to, we would like to thank our closing sponsor today, which is ABMP. And ABMP is proud to sponsor the Thinking Practitioner podcast. So all massage therapists and body workers can access free ABMP resources and information on the coronavirus and massage profession at abmp.com/COVID-19, including sample release forms, PPE guides, and a special issue of Massage and Bodywork magazine where Till and I are frequent contributors. So for more information, do check out the ABMP podcast, which is a great one to listen to also. That's available at abmp.com/podcasts or wherever you prefer to listen there. So thanks again to those sponsors. And you can, as we mentioned earlier, stop by our sites for the handout that we've got on this Thoracic Outlet show today, other show notes, transcripts, and extras that are over there as well. So we can have links to that. You can find them off of my site at academyofclinicalmassage.com. And Till, where can they find that stuff from you as well?
Our site is advanced-trainings.com. Right at the top, I think it says blog or podcast. It's right there. And then if you got questions or things you want to hear us talk about, email us at info@thethinkingpractitioner.com or look for us on social media under our names. At least my name is my name, Till Luca. How about yours, Whitney?
Yeah, and mine is also the same. That's Whitney Lowe over there on social media. And you can, if you will, follow us on Spotify, rate us on Apple Podcasts, or wherever else you happen to listen. If it's a conch shell you pick up off the beach and hear your podcast from there, we'll be there as well.
Nice.
So thank you so much for joining us today. Till, great to be back with you again.
Likewise.
And thank you all
Whitney.
to listeners for hanging out with us again on this discussion. And we will see you again here in 2 weeks.
See you later.